In this presentation, we will take a look at critical care coding, documentation, and billing. This agenda will cover critical care definitions, review of the CPT codes, review of what is considered critical care time, review of services that are bundled and not bundled into critical care, define documentation requirements to support medical necessity, and we'll wrap up talking about pediatric and neonatal critical care services. Critical care can be defined two ways. First of all, we talk about what critical care services are defined as, and then we talk about what the critical illness or injury is defined as. CPT states that critical care is the direct delivery by a physician or other qualified healthcare professional, which would be defined as an advanced practice provider, so a physician assistant or a nurse practitioner, of medical care for a critically ill or critically injured patient. We then have to define that critically ill or critically injured patient, and CPT states that this is an illness or injury that acutely impairs one or more vital organ systems such that there is high probability of imminent life-threatening deterioration in the patient's condition. Critical care involves high complexity medical decision making to assess, manipulate, and support vital function systems. So really what we're looking at here is that you're taking an immediate action to prevent further deterioration of the patient's condition. Critical care typically requires the following elements: interpretation of multiple physiologic parameters, application of advanced technologies to prevent further deterioration of the patient's condition. However, critical care may be provided in life-threatening situations where the above elements are not met. Critical care is usually, but not always, given in a critical care area, such as the coronary care unit, intensive care unit, respiratory care unit, or the emergency care facility. So that means that critical care can be provided on a standard floor. It all depends on the patient's condition. So if you need to take immediate action to prevent further deterioration of the patient's condition, to make sure that they don't have loss of life or loss of a body part, limb, those types of things, then you may be able to bill critical care. Another thing to keep in mind is if a patient is in an intensive care unit, that doesn't automatically mean that you would bill critical care. Again, it's going to completely depend on the condition of the patient. For example, if you have a patient that's in an intensive care setting because they just require intensive monitoring due to maybe a condition of high blood pressure, but they're not critically ill at that moment, you would not bill critical care for those services. You would bill your standard evaluation and management care codes. Critical care requires the full attention of the provider. In order to count time towards critical care services, you as the provider must devote your full attention to the patient, and you cannot provide services to another patient at the same time. Another thing that you have to meet is direct supervision, so the physician must be directly available to the patient at the time the critical care services are being provided. For standard critical care services, there are two CPT codes that we report to capture the total time spent providing critical care services to the patient. These codes are 99291 and 99292. 99291 is reported for the first 30 to 74 minutes of critical care, and 99292 is an add-on code that you would report for each additional 30 minutes beyond the 74-minute mark for critical care services. If you do not meet the requirement of 30 minutes to bill 99291, then you would revert back to billing your standard hospital care codes for subsequent visits 99231 through 99233, for initial hospital care 99291 through 99292. Critical care codes are time-based codes, so that means that throughout the duration of the day, you're going to want to mentally track how much time you're providing critical care services to a patient. Below are listed some examples of what counts towards critical care time. Time spent on the unit or at the nursing station reviewing tests and imaging results, review of outside records, physician attendance during emergency transport, discussing patient care with other medical staff, documentation of critical care services in the medical record, and time spent on the floor unit with patient, family member, or surrogate decision makers when the patient is unable to or lacks capacity to participate in discussions. Examples of things that do not count toward critical care time can include time spent in activities that occur outside the unit or off of the floor, time spent in activities that do not directly contribute to the treatment of the patient, time spent performing separately reportable procedures. I want to make a note about that last bullet, time spent performing separately reportable procedures. This is important for you to keep in mind because there are certain services that you could provide to a patient while doing critical care that are separately billable. So some examples of bedside procedures could include CPR, line placements, those types of things. So you'll want to make sure that when you document critical care time, and we'll talk about that towards the end of the presentation, that time excludes all time that you're using to report those separately reportable procedures. So the question then becomes, how do you document or measure critical care time? You want to make sure that you count all the time that you're spent devoted to the care of the patient. The time does not need to be continuous, so you might see the patient and provide critical care services for 30 minutes in the morning. You might then spend another 15 minutes in the afternoon reviewing some lab results that came back, or maybe reviewing imaging services or items that came back. You could spend another 10 minutes talking to other providers on the care team, and this can all be broken up throughout the course of the day. Another thing to note is that the time does not need to be all face-to-face with the patient, which is unique because other services tend to require face-to-face time. But any time that you spend providing services that are related to the patient's care, they don't have to be face-to-face, and you can count that time towards critical care time. The other thing that I mentioned is that you can track time that you spend performing and documenting some of the following: services that you provide at the bedside that are not separately reportable, reviewing those test results, which could be done later on in the day and not face-to-face with the patient, discussing things with the care staff, and that care staff could include other physicians, nursing care staff, therapy staff, anybody that's directly involved in patient care, documenting those discussions, documenting those lab results, those reviews, documenting any additional medical decision making in the patient's chart, and then time that you might be spending with the family to provide updates on what's going on with the patient, maybe to talk about some decision that needs to happen with the patient. All of those activities throughout the day can be counted towards total time and the time that you use to bill for your critical care. Although you do have opportunities to bill for separately reportable procedures, there are other services that you cannot bill for, and they are considered bundled or a part of critical care services. So for these things, you want to keep track of how much time you're spending because that will be wrapped up into the total time that you use to report critical care. A couple examples here of services that are bundled include interpretation of cardiac output measurements, chest x-ray interpretations, blood gas interpretations, blood draws for specimens. If you're looking at information data stored in the computer, if you're looking at hematologic data, if you're doing gastric intubation, temporary intravenous pacing, vent management, and vascular access procedures are all considered bundled, so you cannot bill those separate with critical care. One of the things I do want to mention about vent management, if you have a choice between billing for vent management or critical care, it's actually going to be more beneficial for you to bill for the critical care services. The reimbursement rates are better, and the work review values assigned for critical care are better as well. I had previously mentioned that there are separately billable services that you want to keep in mind and report those outside of the critical care services. Again, remember, any time that you spend providing these services, you have to carve that out of your critical care time. So a couple things that you want to think about billing if you perform these: CPR, intubation, chest tube placement. These are just some examples of things that are separately reportable, and some examples of services that we typically see performed in conjunction with critical care services. So what's the documentation required to support billing for critical care? I've already stated this a couple of times. Critical care codes are time-based codes. This means that the total time must be documented to support billing. If the time is not documented in the note, we would revert back to billing your standard evaluation and management code. So if it's an initial visit, 99221 through 99223. If it's a subsequent daily visit, 99231 through 99233. In addition to the time element, the documentation must also support the medical necessity to bill for critical care services. What do I mean by medical necessity? The documentation has to support the critical nature of the illness or injury that you are actively treating for the patient. Try to stay away from words such as stable, patient is ambulating in the room, patient is sitting up in the bed having a conversation with us. When you talk about those types of things, it doesn't necessarily support the critical nature of the patient's illness. So you really want to make sure that medical necessity is supported in the record, and we'll take a look at a couple of examples. Stay away from a statement of critical care time 35 minutes. This statement alone is not sufficient to support billing for critical care services. You do want to document that you spent 35 minutes providing critical care, but you also need to document a statement outlining the actions taken to prevent further patient decline in addition to that total time spent with the patient. That statement outlining that action taken to prevent decline is what's going to support the medical necessity that's required to bill for critical care. Critical care services can be reported when working in collaboration with residents and fellows. Below is an example from CMS of acceptable teaching physician attestation for critical care. Patient developed hypotension and hypoxia. I spent 45 minutes while the patient was in this condition providing fluids, pressors, and oxygen. I reviewed the resident's documentation and I agree with the resident's assessment and plan of care. So a couple of things to note in this statement. Number one, we know that the patient became hypotensive and had hypoxia. Number two, we know that you spent a total time of 45 minutes while the patient was in this condition. Number three, we see what you did to provide further to support and keep the patient from further deteriorating. And number four, we see that you reviewed the resident's documentation and that you agree with the note. All of these elements combined will support billing for critical care services that were provided in collaboration with the attending and the resident or fellow. On the flip side, when working with an advanced practice provider, a nurse practitioner, or physician assistant, critical care codes cannot be billed as split shared services. The reporting of critical care codes needs to reflect the evaluation, treatment, and management of a patient by the physician or the qualified APP respectively, and cannot be representative of a combined service between the physician and the qualified APP. APP and physician time may be reported separate from one another, but the time cannot overlap. So for example, the APP may provide 45 minutes of critical care between the hours of 3 a.m. and 7 a.m. They would bill for the 99291 for that first 45 minutes. The MD may provide an additional 30 minutes of critical care between 11 a.m. and 12 p.m. The MD would then bill for the additional units of 99292. So in this example here, you can see that the times did not overlap and that each provider is billing for their own individual time spent providing critical care services to the patient. Let's take a look at some examples that CMS has provided of critical care services. The first example is an 81-year-old male who is admitted to the ICU following AAA resection. 2 days after surgery, he requires fluids and pressors to maintain adequate perfusion and arterial pressures. He remains vent dependent. A 67-year-old female is 3 days post mitral valve repair. She develops petechiae, hypotension, and hypoxia requiring respiratory and circulatory support. A 70-year-old is admitted for right lower lobe pneumonia and has a history of COPD, becomes hypoxic and hypotensive 2 days after admission. These are all examples of patients that may require critical care services to maintain their health and stability. This slide here provides you with the CPT codes and the total time allotments for billing these codes. What's nice about this table is it breaks down the minutes for you and then the total units of the add-on code 99292 that you may be able to bill. So for example, if you provide 105 to 134 minutes of critical care services to the patient, you document that total time in the notes, which is reflective and excluded of any procedures that you might separately bill, and you have medical necessity to support billing for critical care. You would be able to bill the first unit of 99291, which is your base code, and then 2 units of 99292, which is your add-on code for those each additional 30 minutes. If you were to go beyond 195 minutes, the coder would then add up each additional 30 minutes and continue to add additional units of the add-on code 99292. Let's take a look at some practice scenarios. So for scenario 1, how would you code a patient who presents to the ED at 11:25 p.m. on day 1 with critical care services beginning at that time and performed continuously until 12:15 a.m. on day 2 with no more critical care services performed on day 2? So the answer to this one is that you can only bill for 1 unit of critical care 99291, and that's reported on day 1. The reason here is that on day 1 we had just over 30 minutes. So we had 35 minutes of critical care services that we provided to the patient. The clock resets on day 2, so it resets at 12 a.m. on day 2. And on day 2, we only provided 15 minutes of critical care services to that patient. So on day 2, we would report the subsequent hospital care code 99231 through 99233, opposed to the critical care codes. Scenario number 2. How would you code a patient who presents to the ED at 11:25 p.m. day 1, with critical care services beginning at that time and performed continuously until 12:50 a.m. on day 2, at which time continuous critical care services are interrupted? Critical care services are reinitiated at 2:30 a.m. on day 2, with an additional 60 minutes provided on day 2 following the reinitiation. So for day 1, you would report 99291. We had 35 minutes of critical care, so 11:25 to 12 a.m. For day 2, the clock resets, and we had 15 minutes of critical care services, plus an additional 60 minutes of critical care services, which adds up to a total of 75 minutes of critical care services provided on day 2. So for day 2, you would report CPT code 99291 and 1 unit of 99292, the add-on code, which totals 75 minutes. For the second half of this presentation, let's switch gears and talk about pediatric and neonatal critical care. Ultimately, the same definitions for critical care services apply for the adult, child, and neonate, meaning that the patient has to have a condition that requires immediate attention by the physician or other qualified healthcare professional to keep the patient from further declining. Code selection for babies and children is defined by patient age. The codes represent care starting with the date of the admission and all subsequent days that the baby or child remains in critical condition. The initial inpatient critical care code may only be reported once per patient per hospital admission. Subsequent day codes may only be reported once per patient per day or by a single physician. This really means that only one critical care code for the neonate or child can be billed, regardless of how many physicians see the patient on that date of service. Whereas with your standard critical care codes, multiple providers could provide critical care and bill for those critical care services. That's one of the big differences between neonate pediatric critical care and regular critical care. Time-based critical care codes 9929192, which we just spent a lot of time talking about, can be reported on the same day by a provider of a different specialty than who reports the neonates or pediatric critical care codes. So you may have more than one provider doing critical care services, but again, you can only have one provider that bills the pediatric or neonate critical care code, and then the other providers would bill your standard critical care codes 99291 or 99292. Here is a breakdown of the pediatric and neonatal critical care codes. Remember, these are not time-based codes. So the 9929192 are time-based codes, and if you are billing them for pediatric or neonates, you do need to make sure that you meet the requirement of documentation of time. If you're billing the pediatric or neonate codes, then you would bill those based on the age of the patient. So for a neonate that's 28 days or younger, if it's your initial visit with the patient, you would provide critical care services and bill CPT code 99468. If it's a subsequent day code or subsequent day visit, then you would bill 99469. You would bill the 99469 daily until the patient is no longer in critical condition. If the patient is an infant or young child 29 days through 24 months of age, you would bill 99471 for your initial day of critical care, and then 99472 for each subsequent day of critical care until the patient is no longer requiring that type of care. For a young child 2 through 5 years of age, you would bill 99475 for your initial visit, and then 99476 for each subsequent day of critical care services. A code has been established to report services for a child who is not critically ill but requires intensive observation, frequent interventions, and other intensive care services. CPT code 99477 is defined as the initial hospital care per day for the evaluation and management of a neonate 28 days of age or younger who requires intensive observations, frequent interventions, and other intensive care services. Please note that although the code is defined as initial hospital care, it is still billed per day for the evaluation and management of the neonate. If you are initiating normal newborn care, so a patient that doesn't require the intensive monitoring or observations or does not meet the needs or definitions of critical care, then you would report your normal newborn care code, which is 99460, for the first day. For the initiation of care of a critically ill neonate, you would then revert back to the codes that we just spoke about and report 99468 for the first day. For the initiation of inpatient hospital care of the ill neonate, not requiring the intensive observation, and also doesn't meet the definition of critical care, then you could report the standard care codes 99221 through 99223 if it's the first day or the initial day that you're seeing them, and then you would report 99231, 992 through 99233 for each subsequent day service. There is also a series of codes that have been established to report the subsequent days of directing the continuing intensive care of a low birth weight infant. These codes are 99478 through 99480. These are codes that are used for infants and neonates who are not critically ill, but continue to require intensive cardiac and respiratory monitoring, continuous and/or frequent vital sign monitoring, heat maintenance, eternal parental nutritional adjustments, lab and O2 monitoring, and constant observation by the healthcare team under the direct supervision of a physician or other qualified healthcare professional, or your APPs. When the neonate improves after the initial or subsequent day and no longer requires the intensive monitoring, you would revert to reporting the subsequent hospital care codes 99231 through 99233, or you could report the subsequent newborn care code 99462 as appropriate. The low birth weight codes are obviously defined by the weight of the patient. So if the body weight is less than 1,500 grams, you would code 99478. If the body weight is 1,500 to 2,500 grams, you would bill 99479. And if the body weight is 2,501 to 5,000 grams, you would bill 99475. Keep in mind for the subsequent care of a sick neonate younger than 28 days, but more than 5,000 grams, weighing more than 5,000 grams, who does not require intensive or critical care services, but does require hospitalization, you would report CPT codes 99231 through 99233 for each subsequent day's services.